So thank you very much for the invitation. It's a great honor to be in front of a bunch of artists, and I think you hopefully understand what I mean by the midwife being an artist. The Art of Birth is a course which has been running for about 4 years now. We've offered 40 training courses around the world, including Australia, the UK, and in Africa. And as part of a Winston Churchill fellowship, I was really honored to be able to travel around the world to really understand a bit more about birth trauma. So like I said, the Art of Birth has been going for quite some time. It consists of 9 modules, 3 A's, 3 R's, and 3 T's. And it started mainly as an instrumental delivery course, and then quickly expanded from there to really think. So the Art of Birth basically says that we're all artists, whether we're doctors, whether we're midwives, we are all birthing art, essentially. And the true art really comes in the middle where we start to interact. And I often say to people, if we're artists, we should have paints and paintbrushes, but we don't have that on the labour ward, we don't have that in birth centres. But what we do have are the equivalents. So they're the P's, the practical things that we deal with on a daily basis, and there are hundreds, if not thousands of them, if you just think about them as you're sitting. And then there are lots of threes, or having to think in 3 dimensions. And I feel that having done this work for about 10 years now, starting in Africa as a fistula surgeon and then doing all of my training in the UK, I've realized that where things go wrong is where we don't think in 3 dimensions and when we don't start to juggle all of those P's. So the Art of Birth really tries to deal with lots of these P's at the same time. And today I just want to talk about one in particular, which is biomechanics, which I think is really the last frontier. I think we do it on a daily basis, especially as midwives, but I feel that we can still definitely go a lot further. And the reason why I think that's so important is, as far back as the 1920s, people have been saying that, look, we seem to spend so much time picking up the pieces. We seem to assume that it's normal for women to be injured down below. And I don't really think that's the case. We seem to have spent all of our money and all of our research and attention on picking up the pieces and coming up with all these fantastic repair procedures, which we know do not always work in a number of these women. So my work basically has involved working with some really great people. This is Ian Treharne, who I started the Art of Birth training course with. Kees Valdic, for me, he's the most experienced obstetric fistula trauma surgeon in the world. And Hans-Peter Dietz, who's in Australia, and he started to use ultrasound to pick up a lot of these injuries. And I think having traveled, I've really come to a different level of experience. Unfortunately, the videos are not playing. I was hoping to show you some pictures of fistula, but this basically is what fistula is. So this is a woman that's been in labor for days and days and days and days, and then basically everything starts to slough away because of the pressure of that baby's head sitting there for days and days. And then she's left with a hole in the bladder. So you can imagine this is the woman on her back. We've got a speculum holding down the posterior vaginal wall, and you can actually see this hole there going into the bladder. And that's the urethra there. So this is quite a big problem, of course, in Africa. 2 million women have this problem in Africa. We say we don't have it in the UK. I beg to differ. I say that obstetric trauma is on a spectrum. So you may not get to the point where you start to have big holes, such as the fistula, but we have women being pushed in that direction because of stress and strain and maybe tears of varying dimensions. And I want people to think about the fact that whenever there's perineal injury, the chance that actually there's a higher injury to the pelvic floor is as much as 30%, and we are missing it. So it's a pandemic of birth problems, and this kind of ties into the P's again. So it's all about prolapse. A lot of people now know that a lot of the problems that women are facing in later life, whether it's prolapse or incontinence, a lot of it is caused because of the childbirth process. It's not just because of genetics. And of course, there's this big drive now to really think about PTSD, post-traumatic stress disorder. It's all related. And of course, the annual report of the Chief Medical Officer in 2014, this was released late last year, has actually started to say that we need to be more systematic in how we care for women, especially at the time of childbirth and postpartum. So for me, I'm really about trying to prevent the trauma. Because having traveled around the world, many people are telling me now that women they're not designed to give birth to babies. They're not designed, they don't have a nice straight tube where the baby plops out. And therefore, would it not be better for most women to have cesarean sections, especially if they want it? given the experience I've had now traveling to Portugal to a biomechanics institute, I've realized that actually that's not true. If you look at a lot of the literature, women actually are designed beautifully to give birth. And I think this is what we need to bring back. So I often say that when it comes to research or any kind of intervention in birth, we are too sensitive if you think about the research term, rather than being very specific. And this is what art and obstract really is about. So I'm mindful of time, so I'm going to rush through. I have a toolkit that I can send to you if any of you are interested to sort of get you started in biomechanics. But I want you to just think about the pelvic floor and the fact that we're dealing with the perineum most of the time. But on top of that, we have the pelvic floor. And for me, the pelvic floor is the key to progress in labor. And if you get a good understanding of that, that's what will really make the difference. So we know the pelvic floor muscle consists of the pubococcygeius muscle, the puborectalis muscle. It essentially is just a band. So you imagine that this is the urethra there, you've got your vagina, you've got your anus, and you've got 3 bands of muscle surrounding them. So you need that muscle basically to relax and let the baby out. Now, the thing with the pubococcygeius muscle, or any type of muscle in the body, usually it can only stretch to, let's say, 1.5 times its normal length. And so people say, well, the baby's head is so big, so it's going to stretch that muscle definitely more than 1.5. So you're going to rip that muscle, and then, of course, it's going to set you up for prolapse and incontinence. But actually, like I said, the woman's body is nicely designed to stretch more than 1.5 times. And that's because of relaxin, because of estrogen, because of increased elastin. So actually, that muscle can stretch more than that. It can stretch up to 3 times without tearing, without rupturing. But I think there are conditions that we have on the labor ward sometimes that make us stretch that muscle too much or make the muscle too stiff. So sorry, once again, these videos are not playing. But in terms of physiology, like I said, the woman changes her physiology. So instead of having lots of collagen in her obstetric tract or the obstract, she now has lots of elastin molecules. And what the molecules do, they make things very stretchy, which is good for pregnancy and it's good for childbirth. And so what we should be thinking about, and this is what they do in engineering or biomechanics, they tell us to think about stress and strain. So stress is the force which has been applied to that muscle or all of those tissues, whether it's the perineum, whether it's the nerves, or whether it's the muscle. And then also think about the strain. So how stretchy can those tissues go? And it's the combination of those 2 things that cause what we call tissue strength or elasticity. So in terms of our practice, and I think we do it a lot, we do it well most of the time, we need to think in terms of stress and strain. What are we doing in terms of labor ward, in terms of our practice? So we know that the relationship between stress and strain is not exactly a straight line. It doesn't mean that if you stress by 3 times, you're going to stretch by 3 times, but we know the direction in which it goes, which is like this. So the more stress you put on the tissue, the more load you put on the tissue, of course, you're going to stretch the tissue even more. Now, the other thing which is really important that I discovered as part of my research, of course, is that if you assume that this is the ideal situation for those muscles and those tissues, whether it's the perineum or the pelvic floor, then you don't want to have a situation where the tissue now becomes like this, really fatigued and really stiff. And so what I was trying to work out in terms of practice is what makes the tissue become less elastic and what makes it more stiff. And there are just 3 factors that cause that. So it's time, temperature, and water. So I just want you to think in terms of your practice. Like I said, I have a toolkit that I can send to you. But if you think in terms of, let's say, temperature, for instance, do you think it's good to have a high temperature or a low temperature? What's less likely to cause those tissues to rupture? Less or high? Yeah? Okay. So some people will say high would make it rupture. But at the same time, if you listen to people like Michael Odont, where he talks about having a warm birthing environment, actually, warm tissues are actually quite good for the mother as well. It's just that you don't want it to go too high, because if it goes too high, it dries out the tissue. And then, of course, it then starts to impact on this factor, and then you have a problem. So you start having tissues which are very stiff. So that's just a brief introduction to biomechanics. And what I often say to people when they come for training is that we need to think about the fact that we're dealing with 3 classes of women. We're dealing with women who are able to give birth by themselves. They can give birth by themselves, and usually they do that with no intervention and have no problems. Then we're also dealing with another subset of women who are unable, for whatever reason, to give birth by themselves. And this is where we have to come in as work out who those women are. Those women should have a cesarean section rather than pushing them to go and have birth, that's going to rupture their tissues. But it's quite a small subset from my experience. The biggest subset I think that we're dealing with at the moment are this kind of gray area, the able but disabled woman. The woman who we are pushing from the able camp, but we're disabling her because of our practices, or those ones who are unable completely, but because we haven't assessed them, they now go into the let's push and push and push and push, and then we end up rupturing the tissues. So I think we kind of have to think a bit about our practices and what we're doing. And what we're trying to do with the Art of Birth really is we're trying to get to a situation where we work with those tissues. We work with them. If a woman comes very dry, she comes with a temperature, we start as artists to deliver art that will reduce the trauma occurring to those tissues. And you can see where most of the trauma is going to occur. It's usually at the time of crowning. If you look at the color of the pelvic floor, when it starts to change color, that's where the most stress is. So it's when the baby's head crowns, especially at the BPD, that's where you get the most stress. Then, of course, just underneath the pubic bone, you can see how much stress is actually occurring there. So these are the points where we really need to think about trying to intervene. So I often say that, look, it should be, birth should not be treated as, it should say here, actually, intervention or pretension, but actually we should be intending to do something when these women come. We can't treat them all the same. We have to really think about these three things and how they interact with those tissues and start adjusting them. Like I said, because we're artists, what we're going to birth every single time is going to be completely different. So you want to be able to assess correctly and then decide from there what you need to do. So I'll just go for a few more slides. I don't know how much time I have left. 15, wow, okay. So we know that we're dealing with the pelvic floor. And we know the pelvic floor basically becomes thicker during pregnancy. It becomes thicker because of increased abdominal load. Now, this is another modification, which is good for the mother. It's good for the mother because it makes the pelvic floor strong. And from a biomechanical point of view, a strong pelvic floor actually stretches more. So as long as it's hydrated, she's not pyrexial, you're giving her enough time for it to stretch nicely, you shouldn't really have any problems. Now, this comes from a small manual that I've written, and basically it's just getting you to think about the pelvic floor. And I think this is really important to think about in terms of position, because remember, we're artists now. We are dealing with engineering and biomechanics. So if you imagine this is the pelvic floor, we know when it contracts forward and it contracts up. So if the woman is going to relax, she needs to relax in what direction? Down and... So if the pelvic floor is contracting and it's contracting forward, so towards her belly and upwards, to relax it, you have to go in what direction? It goes down and backwards, yeah? So these are things that we need to really train the woman to do. And I feel that sometimes from a birthing point of view, and this is where I'm really now trying to mobilize artists around the country to really start doing a different take on childbirth classes, to really train women how to do this. This is really having a big impact. And of course, the other thing that you need to think about with the pelvic floor in terms of position, we know that the reason why we've adapted the way we have and the reason why we have such a strong pelvic floor is because we don't want all of our organs to fall out. So when we're now having a woman upright, in an upright position, of course, the pelvic floor is now going to be stronger. It's going to be 92% stronger than if she's lying on her back. Now, that can be a good thing, but of course, when she now wants to push and deliver the baby, it can be a problem because sometimes those tissues can resist you trying to deliver the baby, and it can be a problem. So once again, we have to really think about how do we get that woman to relax that pelvic floor when she's in that upright position. Because for me, upright is the best position, but at the same time, you can be doing her a great disservice by trying to get her to push in the upright position, and she doesn't know how to relax. It's almost like, as they say, having a tube of toothpaste, and she's using her abdominal muscles to try and push the baby out, but the cap of the toothpaste is still on. So, of course, what happens is that everything basically ruptures, or the baby, or she doesn't make any progress. The other reason why I think it's really important to really think about the biomechanics of pushing and what she's doing is, if you think about the pelvic floor is attached to the coccyx. So the whole reason why people say, yes, we should have the woman upright is because it opens up the pelvis by 30%, which is true. But on the other hand, you can actually be reducing the effect of that because of the fact that the pelvic floor is attached to the coccyx. So when she's upright and she has a nice contracted pelvic floor, it brings the coccyx in. So once again, you need to get that situation where she starts to relax. In terms of our biomechanics training, the other thing that we do is we really get people to start thinking about the muscles that the woman has, because she uses that quite a lot when she's pushing. So we know about the transverse muscles, almost like a big corset around the woman's tummy. And then she has external and internal obliques on either side that also play a big part. And then she has her rectus abdominis muscles, which are basically in pairs on either side. Now, these muscles are quite strong, but she needs to know how to use those muscles. One of the big problems with these muscles usually are together when she's not pregnant, but when she becomes pregnant, they separate. Now, that can be a big problem in terms of pushing and trying to push effectively for several reasons. But one of the main ones is this. Pelvic floor, this is a rectus abdominal muscle, which is intact. So you can't really see this here because it's white, but this is a uterus which is there. So the uterus now is flat. It's aligned with the birth canal. And when she's standing upright, that also aligns it with the birth canal. So they're working together. But when she now has no support at the front, because she's now got diastasis or splitting of her muscle, then what happens to the uterus is the uterus now, and you can't really see this, the cervix now is out of alignment with that birth canal. So you have a woman actually who's standing up, she's doing her best, you've done the best that you can for her, but she cannot push the baby out just because she has that diastasis. So these are the things that we really want to get people used to, especially in terms of antenatal preparation. I think it's really important. And then quickly, I'll just go into pushing. And I've gone through this already, the fact that we know that the pelvic floor, when it's stronger, it stretches more. And of course, it's going to be stronger when she's standing up. But I want to spend a bit of time talking about the types of pushing. So in Finland, where I'm going to go and do the next part of my biomechanical fellowship later on this year, they have a very low cesarean section rate. I think it's about 15%. They don't do interventions like forceps or vacuum like we do, but it's really low. And when I asked them, what they said is passive pushing. We allow that head to come all the way down to the perineum. And for me, this is really important. I mean, as part of my background, I have worked in 3 massive African hospitals where they deliver sometimes 100 babies a day. And the thing that really changed my practice there was just allowing the woman to push when she felt ready. Let the baby come down. The damage is caused when she starts pushing. The damage is not caused by the baby just sitting there and nothing's happening. So if we have 3 hours, for instance, for the primates in terms of NICE guidelines, can we not make the most of those 3 hours to give that woman time for that head to come down, especially with a primate epidural? She's not pushed before. It's a malposition at spines. Why do we have this 1 hour period where we say, okay, fine, 1 hour, then she starts pushing? It fatigues the woman. Most women cannot push for more than 30 minutes. It's not possible unless they've really been trained. So I believe that passive pushing really needs to come back. And I think if you really want to avoid prolonging that second stage, please prolong the passive stage. I think there needs to be like a change on our labour wards where, for instance, in Southend, I think they wait until that baby's head comes down to the perineum and then she pushes 20 minutes and then the baby's out. And then, of course, the perineal pushing or the poo phase is what I like to see. So like I said, working in some hospitals in Africa where you're the only person on and you have 50 women in the bed, you haven't got time to go around and do VEs. I don't like doing VEs anyway. I think I won't say it's a waste of time, but do a VE because it's going to give you information. But I look for the poo phase. I look to smell the poo, and then I look, it's true, you want to smell the poo and you want to see if there's poo there, and if she feels the urge to push, you allow her to push. Most of them, if you leave them alone, will push by themselves. And I think the other reason why pushing is so important, if you think about that pelvic floor, it's that stress and strain curve again. You have a woman who is pushing. Now, if she's pushing by herself, this is what happens. By the time you now get a situation where she's now doing directed pushing, you're trying to push her, or you're trying to get her to push, you're now increasing the level of force or stress on those tissues by up to 120 newtons. Then, of course, you now want to maybe say, okay, she's not making progress because maybe what you've been doing on the labour ward hasn't been working. Instrumental, either a vacuum or a forceps, will now add an extra 113 to 200 newtons of force on those tissues. Now, you can imagine if this is a woman who has been in labour for a long time, we've dried out those tissues. She's dehydrated, she has a high temperature, and then you want to go and put the forceps in, or even doing a vacuum, you're going to rupture those tissues. So at the moment, forceps has really bad press. Forceps have been shown to cause quite a number of injuries to the pelvic floor now. Maybe up to 30%, 40%. It's been picked up by Hans-Peter Dietz in Australia. But I think I wouldn't blame the forceps. I think I'd blame the conditions in which those forceps are being used, and even the conditions in which the vacuum is being used. So for me, the pushing at that perineal phase has to be very, very specific. And there are two types of pushing you can get the woman to do. And this, once again, is borne out by research. There's the triple type of pushing, where you say to a woman, contractions come now, hold your breath, push 3 times, push, 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 take a quick breath again and push, 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 push. Don't make any noise. And of course, when she doesn't make any noise, she holds things in, she increases pressure in her chest, that stops blood going to her heart, decreases oxygen. Those muscles need oxygen as well. They fracture, they're stiff, they don't stretch. So the other type of pushing, which is really important, is what they call peak pushing, where you wait until the contraction is really strong. Head should be at the perineum, wait until it's really strong, and then just get her to give one big push as long as she can. That is the best in terms of pushing. Now, the triple pushing is really good in terms of duration. You can actually get her to push that baby out a lot quicker. But of course, triple pushing causes fatigue. It dries out the mother. She becomes very tired. And what does drying out do to the tissues? It makes them very stiff. They're less stretchy. They're more likely to rupture, especially when that baby's head's about to come out. Now, peak pushing, of course, may take a bit longer, but the woman will not be dry, she will not be tired, and she'll be more willing to sort of invest or participate in the process. So it's a question of getting that balance. And like I said, my issue with the triple pushing is I feel it fatigues the muscles more. It pushes that curve in that direction for those muscles, and they're more likely to rupture. So for me, the question is not how long has she been fully. This is one of the common things we have on label. How long has she been fully for? 2 hours, 3 hours? Okay, we need to do something. I don't care about that. I'm more concerned about how long has she been pushing. Because then I'm now thinking, oh my God, she's been pushing for so long. What has that done to the tissues? Now, this is just to demonstrate that, the bigger the baby's head, the bigger the strain. And it kind of goes back to that slide I was telling you about, those 3 categories of women, the able, the unable, and then the able but disabled. And as much as possible, I really do believe in normal birth. But there's some women that I know, and they're a very small group of women that cannot do it. I'm not going to push them. I'm sorry. I feel if I push them, I'm going to damage those tissues. And like I said, it's not so much, the outcome should not so much be a live mother and a live baby. We have to think about these tissues as well, because long term, this sets the woman up for prolapse and incontinence. So I'll rush through just so we can get some questions. But I just quickly wanted to end with this, and the fact that, as I say, I tend not to do vaginal examinations now. And I tend to really teach my trainees how to do examinations that will give them the most information. I find that most of the time when people do examinations, there's a lot of information which is missing. And at the same time, they're so embarrassed when they're in there that they miss out a lot of information. So now I have a really logical sequence. I've expanded position, as in position of the baby's head, into something which is more three-dimensional. So position now stands for palpation, open, feel for the sagittal suture. Is it in line? Is it synclitic or asynclitic? Is there any tissue swelling? Where is that in relationship to the spines? Is there any overlapping of the bones? Now get her to push down, do a dynamic vaginal assessment as opposed to a static assessment, and then assess the neonatal condition. This is what gives you that 3D idea in your head of what's going on. And when it comes to things such as open, I like to think about things such as warm and moist. Often as doctors, we scoff when we see that in the notes. Oh, the vagina was warm and moist. But now, warm and moist for me, having the experience I have, takes on a whole new significance. Because warm and moist suggests to me, okay, it's warm. It suggests that the tissues must be a bit elastic. And it's moist. She's hydrated. That's what I want to see. So using something like this, it's really started to transform people's practices. And I have a few cards I can give out at the end, and at the back of the card you have something like this, which I will just rush through. But it's just my way of determining, using those findings, what should be the next best thing to do. This is very slow. But I think the key thing with this that we call the recruit matrix, it basically just takes all of those position findings and helps you to decide what do you do with that mother. Is this an easy delivery? And most of these ladies are actually easy deliveries. We don't have to do instrumental deliveries. You don't have to do cesarean sections. They might just be in the descent phase. Or it might be that, sorry, this has taken a long time. it might be that maybe this baby hasn't flexed yet. Maybe the baby is still at the spines or maybe just below. In that situation, what do you do? And then the complex deliveries are the rotational deliveries. So, of course, you don't, when you do your position finding, find yourself neatly in one column. Usually, it's a mixture of things. And your job as an artist basically is to work out what's going wrong in each of those boxes and how can I start to adjust it. What I say to people, they say, what do you do at this situation where you have a rotational delivery? Do you go and do a key lens or do you do a rotational vacuum? I say, no. My job when I assess the lady is to try and push the woman in this direction. So I have to do things in terms of my practice that are going to push the woman in that direction. So I'm just going to end by talking about the campaign that we have to really start to develop artists, especially among the midwives, because you deliver most of the babies. And actually, a lot of what I've said now is not new to any of you. I think the difference is sometimes when you're trying to explain that work to your colleagues and you're trying to tell them, give the woman more time, or I think this is the reason why things are not working, not having a narrative or a structure can be very, very difficult. But I think now having a narrative or a structure, it really does make a big difference. So I think we need to kind of change our language and really show that we know what we're talking about in terms of stress and strain on those tissues, and then the hydration and the temperature and why it's so important and why it's so important to give her time. All of these things are the things that will impact. So I end it there. And like I said, I'm free during the break to talk to anyone who's interested. And like I said, I do have a Getting Started toolkit. It's a very simple biomechanical toolkit that will help you to go through each of these areas and really start to think about how can you now start to embed it into practice? How can you teach your student midwives? How can you use this as a focus for discussion when a woman hasn't made any progress? Let's look through the notes and see where things went wrong and how we can improve things. And of course, ultimately, I'm hoping to get more midwives on the team as artists, delivering this biomechanical childbirth class to these women to teach them how to push and how to relax the pelvic floor. I think it's really important. I think this is what's really going to change the tide of how we deliver birth. Like I said, birth at the moment is under attack. I've been around the world. People are now saying women should have cesarean sections. They're not built for it. And I don't believe that's true. And I think in the UK, where we still have one of the highest rates of trauma-free birth, I think we can really set a precedent for what the rest of the world should be doing. Thank you.
That's great. There'll be a chance to answer questions. Are you yours? Oh.